This is Angie Brenner, again, Director of Federal Programs. Leslie and I kind of tag team here throughout the presentation. The first that we'll go through is kind of an overview of what we're going to discuss today. We're going to briefly discuss the home and community-based federal rule assessments we performed in 2015 and 2016, the initial CMS approval of our statewide transitional plan, and then we're going to discuss additional guidance that we provided back in March of 2017. About is just the federal home and community-based rule. This was effective March 17th, 2014. CMS, the Centers for Medicare and Medicaid Services, which is the federal body that provides our federal match for waiver services. They're the review our home and community-based waivers for approval and have authority over the services that we're providing. They're the ones that posted the federal rule. Their intent of the rule was to ensure individuals receiving services and supports through the Medicaid's home and community-based services have full access to benefits of the community living and are able to receive services in the most integrated setting and really designed to improve the quality of services for individuals receiving home and community-based services. And in reality, what was codified, we should have already been doing, what all states should have been doing with their home and community-based waivers. Here in Missouri, our first home and community-based waiver was implemented in 1989. So it shouldn't have been a whole lot different than what we were already doing, but just a way to put that in writing and then a way for us to work with the federal government to implement what we're proposing and what we have books. A component they put into the federal rule, they needed to make sure that the states were moving towards compliance if they weren't already compliant. They required all 50 states to submit a transition plan to show CMS and all the stakeholders how they would be moving towards compliance. Okay, talk about some of those first steps that we took as we were developing our initial plan. So, the HCBS rule required all states to determine where they were meeting compliance and then where we needed to transition to compliance. In order for us to establish a baseline, we needed to develop self-assessments for our providers and for our waiver participants. So the provider self-assessment, this was released in June of 2014, and we incorporated CMS exploratory questions into an online survey. One of the things that CMS did was provide it to all states and to stakeholders very exploratory questions that address all the requirements in the federal rule. And so this is to help providers, participants, and states to kind of figure out where they were with compliance. So we wrote the bulletin in August 2014 requiring the initial provider self-assessment survey, and also released the Missouri exploratory questions for assessment of HCBS waiver settings to help providers identify if their services were integrated in and if their participants have access to supports in the community, including opportunities to seek employment, work in competitive integrated settings, in community life, and control their personal resources. So links to those self-assessments, we still have surveys on our DMH website, which will have links later in the presentation. At that time, we did not require that providers complete these surveys, but we did strongly request them to. 35 providers statewide submitted these self-assessments, our 600 to 700 providers. So the response rates were a little, they weren't a statistically valid sample. With the participants, we requested surveys from them as well, and that was towards the end of 2014, November and December. These surveys were developed utilizing a modification of the CMS exploratory questions with input from self-advocates, the selected individual experiences to determine if their settings that they lived in or received services in were compliant with the HCBS final rule. The surveys included identification of the setting types and the state use those to utilize information for follow-up to the setting if needed. They provided the option for anonymous or to include contact information if participants wish to have follow-up communication with the state. If the participant requested an on-site assessment, we performed on-site assessments, and 300 participant surveys submitted to the state. To really compare the provider self-assessments to the waiver participant surveys and validate any inconsistencies. However, since there was not a statistically valid sample between the provider and the participant self-assessment submissions, the state proceeded with a random sample of service settings to look at. So with that random sample, when we looked at settings, we had to look to make sure that settings did not have the appearance of an institution or isolating or segregating. And then we at the HCBS required a heightened scrutiny review process. And it was determined to be heightened scrutiny was that through a mapping, which we called GIS, Geographical Information System, with mapping with the Department of Mental Health providers, Department of Health and Senior Services, Health Net Division, and Office of Administration pulled this mapping together. So when it was identified as heightened scrutiny, or that was identified through the random sampling, we formed on-site assessments of those in 2015 and 2016. And total approximately 1,200 settings the state completed. Okay, slide. We'll talk a little bit about our statewide transition plan. CMS required all states to submit a statewide transition plan to outline the steps that the state and the providers would have to take to achieve compliance. We worked several versions with CMS on this statewide transition plan that we're going to refer to as an STP. CA of Missouri, their initial approval in March of 2017. Initial approval, we began to move forward with provider remediations from the on-site assessments that we did in 2015 and 16. Basically, that transition plan, we had to work through with the federal government on how we were going to move providers and our system, the state system, through the remediation process of getting all of our manuals, our regulations, policies in line with the federal rule. So CMS is requiring the state to make additional changes for their final approval of our transition plan, and they're outlined in the CMS initial approval letter, which we have posted on our website. And in that third column on the slide is linked to that approval letter. The state is currently working on these changes, and those will go out for public comment before the final submission. One thing to make note of is that if you pull up the federal rule, it initially had an approval deadline of March 2019. After CMS initially approved Missouri's transition plan, they extended the compliance date to March 2022 because many states were having issues on getting into compliance by 2019. However, I say that Missouri has moved along very well with their providers and with their stakeholders on this transition. We've had a very clean transition plan. It had March 2019 as the final date. CMS, during a phone call with us, did ask for the state to leave March 2019 in the transition plan, but allow for us and really request that we use that additional time through 2022 to address any specific issues if we're struggling on meeting the March 2019 deadline. The slide we have provided here, the guide that we sent out in March of 2017. This has further guidance that we have learned through work with CMS, work with other states. It's guidance to help providers and families to think about the intent of the requirement, examples of evidence that could be submitted for HCBS compliance. The document is also posted on our website, and we'll go through it here today with you. This is a very simple slide, but it's a very important slide. On-site assessments through this sampling back in 2015 and 16. So we only captured a portion of the providers. However, the to all settings, service settings. So, loan certification, provider relations, targeted case management, technical coordinators, and quality enhancement teams have incorporated all of the HCBS requirements into their review tools. And so they will be going out as part of their reviews and reviewing the HCBS components. Everyone will need to be in compliance. So if you were not part of the on-site assessments, you still have to make sure that you refer to the guidance that we've provided and to the federal rule, because it will be incorporated into your ongoing monitoring reviews. So with that, I want to go ahead and start digging into those requirements and then help you kind of walk through the guidance and then examples that can be submitted to the monitoring teams. So I'm going to turn it over to Leslie Bradley.
Thank you, everyone. This is Leslie Bradley. I'm the Program Coordinator with Federal Programs Unit. And Angie mentioned I'll be walking you through the guidance booklet. The document, as Angie said, really includes the federal rule language with the rule citation, the guidance to help providers think about the intent of the requirement, and, as she said, examples of evidence for HCBS compliance. Now, in addition to this guidance booklet that the division put out for your use, the division also posted sample HCBS policy practice language guidance, a sample participant services handbook, as well as a sample HCBS staff training record. And these three documents are all located directly beneath the guidance document, and the link to that guidance was on the previous slide. Keep in mind, not all of the example evidence that you're going to see in the column in the guidance document is required. However, there must be enough evidence for the provider to show how the compliance has really and truly been incorporated into their systems and overall agency processes for all the individuals supported in all waiver services that the provider provides to the individuals. So why they must provide evidence if the requirement is already documented in individual support plan, the ISP. And while it's true that the ISP templates address and document the HCBS requirements for the individual support plan guide that went into effect in January of 2017, lines the mandatory requirements, the HCBS compliance is truly a collaborative effort between targeted case management, or TCM entities, and provider agencies. Provider agencies must show how they are working with TCMs to support individuals and how they, too, are meeting the compliance with the federal rule. So we will discuss the 23 HCBS requirements that are contained in this guidance. The first 14 apply to all waiver services except for 2, which address choice of roommate and room and board. And I'm sure to point these out, these 2 only apply to residential services. The next specifically for provider-owned and controlled settings, and the 3 apply to heightened scrutiny settings. When HCBS requirements, it's important to keep in mind that DMH waivers are home and community based, meaning that they are provided in the home and community and not in an institution. The HCBS requirements ensure that waiver service settings are home-like, non-institutionalized, and that individuals are integrated in their community and not segregated or isolated. So I started with the first one. The setting is rated in and supports full access to the greater community and engagement in community life. The requirement that we're going to go through has specific CMS language that, as a provider, you'll want to make sure to incorporate into your evidence and overall systems. So, for example, with this first requirement, integrated in and supports full access to the greater community is language you should infuse into your provider policies, your staff training, and your participant handbooks. Providers find that when reviewing this guidance, they're really already doing a lot of this, but they may not have a written policy, documentation, or staff training. I know we've heard a lot of that during workshops and during assessments. So make sure to document your practice or what your agency is providing as evidence of HCBS compliance. For example, providers have reported that they complete monthly community mapping with individuals so that individuals are educated and informed of activities, services, transportation options, and really all the opportunities available to them in their communities. Many providers are probably already doing a lot of this work needed to meet these requirements, but we know that they're just not documenting it. Make sure to give yourselves credit for the great things that you're already doing. CMS and continues to provide additional guidance for the HCBS rule, and such area refers to reverse integration. Now, to explain what reverse integration is, take, for example, a day habilitation site where members of the community, maybe say the Boy Scout troops, come to the site to provide activities and interact with the individuals receiving the day habilitation services. CMS has provided guidance that if reverse integration is the only activity and community interaction that individuals receive, they give the appearance of segregating and isolating individuals from their broader community, and for not meet HCBS compliance. The intent is not to take these activities away or say that they can never happen, but to ensure that individuals also have the opportunity and choice of activities, interaction in their community outside of that day habilitation site. Again, HCBS waiver services need to be integrated in and support full access to their greater community. As that we will review today, providers need to consider if they have a policy procedure to address this requirement. Are they training their staff? And are they informing and educating individuals and or guardians about the HCBS rule? And or guardians need to understand their rights and the choices that they have because of the HCBS federal rule. The next requirement, the setting provides the opportunity to seek employment and work in competitive integrated settings. The employment initiative is a huge emphasis for CMS. As an agency, you may not specifically provide employment services, but there is specific guidance for you on how to support an individual who wants to work and accommodate that individual's transportation, mealtime, medication times, if they do obtain employment. For providers of employment services, there are examples to consider as well as information on what providers cannot do, restrict or coerce an individual from seeking employment, gaining a certain type of employment, or increasing hours at a job.
And it's important to the environment is that CMS is not requiring that everyone go out and get a job, but it's the fact that everyone should have opportunity to work in competitive integrated employment. Here is extremely important, and it's the focus of many national efforts between CMS, Department of Labor, and Administration for Community Living. Here in Missouri, we even have an Empowering Through Employment initiative going on.
So important emphasis. Next requirement, the set supports control of personal resources. This also includes personal possessions such as television, stereo, furniture that the individual has. Resources and possessions should not be restricted by the provider unless indicated in the individual's ISP and reviewed by due process. The net supports individuals to receive services in the community to the same degree of access as persons not receiving Medicaid HCBS services. This requirement is similar to the first requirement, which spoke to integrating in and supporting full access to the community. Therefore, evidence of compliance could potentially be the same for both. However, keep in mind and consider whether individuals have access to medical, behavioral, and therapy services in their community, just like you and I would. The net selected by the individual from among setting options, including non-disability specific settings. The CMS, which is very important to incorporate into practice, is non-disability options. So individuals have choice of setting for the waiver service they are receiving. Did they have opportunity to visit non-disability settings when choosing a place to live or receive services? The choice of activities that include individuals who do not have disabilities, and have choice of working in integrated settings in the community. Are given non-disability options in all aspects of their lives, or do they only have disability options? For example, we've received questions from providers who've asked if this requirement means that individuals cannot participate in Special Olympics, as this is an event only for individuals with disabilities, or attend provider dances, as these dances are typically limited to individuals with disabilities. The individuals can attend these events if they choose. Again, it is not the intent to take away activities of their choosing. However, if they are the only choices that are provided to them, then it will not be HCBS compliant. We have ensured that they have choice to attend activities with individuals who do not have disabilities. I think you'll find that the sample policy that is posted really explains this requirement very well. How does the provider promote integration in and provide non-disability options for individuals regarding where they live, learn, work, and enjoy life, just like you and I do in our community? Is the sections identified for an individual are supported by an assessed need and documented in the person-centered service plans based on the individual's needs and preferences. This requirement addresses how providers are ensuring that they are meeting the individual's needs and preferences. As a provider, you're training staff on the ISP initially, and anytime there's a support need change or amendment to the ISP. This also speaks, though, to the process when there is a rights restriction or any modification to any of the HCBS requirements. CMS provided very specific language and outlined exactly what needs to be included in ISP, along with what providers need to do in order to support an individual with a modification to any of the HCBS requirements or rights restriction. The following CMS language and processes are incorporated into their practice and staff training. Modification or restriction of a right must meet the following requirements reviewed by the Due Process Committee and documented in the individual's ISP. And those include that the specific assessed need is addressed, documented, and justified, the pensions and supports that were used prior to any modifications, lessons of meeting the need that were tried but did not work, a clear discussion of the condition that is directly proportionate to the specific assessed need, run and review of data to measure the ongoing effectiveness of the participant, assurances and supports will cause no harm to the participant. If it has a rights restriction indicated in his or her ISP, then PER will collaborate with the support coordinator and other providers to collect data, attempt alternative strategies, and work towards reinstating the restriction over time. An external advocate, which is actually a state requirement, and the right of the individual to participate in the process. Next, setting provided the individuals with the option for a private bedroom. So this one and the next one only apply to residential services, and I told you I would point that out. So this is this one, and the next one will address room and board. This required private bedroom only applies to residential waiver services, as I said, and it does not say that an individual must have a private bedroom. Individuals be given choice of a private bedroom. So we've had persons ask, if a group home does not have the option for a private bedroom, then is it HCBS compliant? And the answer, as long as individuals are educated and informed about their options and understand that they will need to pick a different provider if they choose and want to have a private bedroom. So if they choose to share a bedroom, they can request that private space be provided to meet with their visitors. Now, individualized supported living ISL settings are required to provide a private bedroom unless, for example, a married couple requests to share a bedroom. The person-centered service plan documents the options based on the individual's resources available for room and board. Again, this only applies to residential waiver services. The person is more than welcome to have a policy and procedure, but the only evidence required would be documentation in the ISP. The ISP will need to indicate the individual's options for housing based upon that individual's resources available, such as SSI vouchers and rental assistance options that were considered when looking for a place to live. Those are just examples of what could be included. The NEN ensures the individual's rights of dignity and respect. The provider has standards for staff to have positive interactions with the individuals and in a manner in which the individual would like to be addressed. Provide trained staff to ensure that individuals are groomed as they desire in a respectful manner, and individuals are dressed in their own clothes of their choosing, appropriate to the time of day, and ensure that dining affords dignity to individuals. So a sample policy that addresses code of conduct as well as the setting for this requirement for dignity and respect. The next thing ensures freedom from coercion and/or restraint. There are two very important pieces to this requirement. The first is coercion, and then, of course, restraint. Either have a restraint policy or they've reported to us that they are restraint-free, which is indicated in their policy and documented there. What needs to be incorporated into practice and evidence is how are individuals informed and educated about who to contact or the process to make an anonymous complaint, Department of Mental Health, or the DMH Office of Constituent Services. The number for constituent services is contained on the DMH website. A link will be provided on the next to last slide of this presentation. Typically have a grievance complaint policy that is given and reviewed with individuals and or guardians, but it does not contain the anonymous complaint process. Individuals and or their guardians need to know that at any time during a grievance or a complaint, they have the right to call constituent services and can remain anonymous. So as a provider, how are you providing this information and making sure that the phone number is accessible to the individuals and guardians if needed? This ensures that individuals and or guardians have the means to file a grievance or complaint without fear of retaliation.
So addresses where waiver participants express in the past that they may make a complaint because they fear retaliation of their direct care staff. Direct care staff may not be quite as nice to them or may make their daily living a little more complicated through subtle or not so subtle actions. It's one of those things that we really need to make sure that they're addressing with the participants and that ability to make those complaints without that fear.
The requirement, but does not regiment individual initiative, autonomy, and independence in making life choices. So this is how providers gather input from individuals on their daily schedules, choose their own schedules, and give input into the activities they want to participate in each day. This requirement does not say that individuals get to do whatever they want every day. To do what I want every day, neither does Angie. If I did, I'd be laying on a beach and picking up seashells. So we all have natural limits in our lives that set parameters for what we can and cannot do, and this is the same for the individuals that we support. Natural limits could include limitations within our budgets, the size of the home we can afford, the number of vehicles we have, staff ratios and availability, as well as the support needs outlined in an individual's ISP. Now, taken into consideration when planning daily schedules and activities. Provides about individuals who choose to live in rural communities and, as a result, may have limited activities and opportunities as compared to someone residing in a metropolitan area. If the individual has the same choice of activities and access to that rural community as others not receiving HCBS services, and that individual has chosen to live in the rural community, then they are HCBS compliant. The setting optimizes autonomy and independence in making choices regarding with whom the individual interacts. This is very similar to the last, except that this requirement addresses visitors and the relationships that individuals are building. Individuals can invite family and friends to their home at any time. A provider asked us about an ISL where gentlemen were being supported. The individuals got together and decided that they did not want visitors in their home after 9 p.m. The provider asked if this was acceptable. And yes, this would be HCBS compliant because the three individuals agreed upon and set their own house rules. The individuals are enforcing that rule that they set. CMS has provided additional guidance regarding house rules set by providers for all waiver participants. This will be HCBS compliant because provider house rules have the appearance of an institution. The link to CMS guidance will be provided again on the next to last slide of the presentation.
Another we've heard in the field a lot is that people don't want to live or leave their work employment because they don't want to lose their friends that they work with. We need to make sure that we're supporting those friendships outside of work. So just because someone is leaving the workshop or leaving a place of employment because they have found something else doesn't mean that the friendships they've developed in that work environment have to end. They can get together in the evenings, they can get together on the weekends, and we need to support them in that.
Okay, requirement, the setting facilitates choice regarding services and supports and who provides them. Now, guardians are given input on services and supports, and they need to know how and to whom they can make a request for new services, supports, and/or provider. Know that a lot of choice and planning occurs during the ISP meeting. However, the individual and guardian needs to know that they can request a change of staff, provider, or if they have the need for a new service at any time during the year, then how is that accommodated? How does the provider ensure that they're accommodating and assisting with these requests, even outside of the ISP meeting? They need to have input on which staff support them. Examples include providers offering individuals the opportunity to participate in staff interviews. Maybe staff meet the individuals before they start supporting them. A lot we've heard that new staff will job shadow before providing supports, and also that agencies are completing and providing satisfaction surveys or even going out and talking with the individuals monthly regarding their satisfaction with staff. Providers have policies that address resolution to conflicts between staff and individuals.
Les provided some great examples here when we talk about staff job shadowing, participants being able to participate in interviews. One area of concern that we heard through various on-site assessments was that individuals may come home from work to find a staff person in their home that they had never met before, or that they weren't even informed that they were receiving new staff. And so that's a little intrusive and a little concerning whenever you come home to your home and find someone new there and you didn't know anything about it. So it's always important to keep the waiver participant involved through any staffing issues that you have need to address.
This ensures the individual's rights of privacy. So all participants have a right to privacy and will have the opportunity to assist in the selection of a roommate, housemate. They need privacy in their bedrooms. And if participants share a bedroom, then they need and should be able to request private space to meet with a visitor during day services. Extra aid to ensure privacy in bedrooms and bathrooms, except when assistance is needed and documented in the ISP. And later, consider how you're ensuring that staff are respecting an individual's privacy. For example, how is privacy afforded to individuals who need extra assistance with activities of daily living? Okay, now move into provider-owned and controlled. So the next 6 HCBS requirements only apply to provider-owned and controlled residential settings. Provider-controlled is defined when the provider of waiver service has a direct or indirect financial relationship with the owner of the residential setting. So service definition, we know that group homes are provider-owned and controlled. Other owned and controlled settings include homes where ISL services are received that are owned by the provider, and all host homes because of the financial relationship between the provider and the staff who owns the host home. Now, when assigned by the provider, there is the potential for the setting to appear institution-like, as has included these 6 additional requirements for provider-owned and controlled settings to ensure that the settings are home-like and not institutional. So the first is that the unit or dwelling is a specific physical place that can be owned, rented, or occupied under a legally enforceable agreement by the individual receiving services, and the individual has, at a minimum, the same responsibilities and protections from eviction tenants have under the landlord-tenant law of the state, county, city, or other designated entity. So very is the lease agreement requirement. In provider-owned and controlled settings, providers must have a lease or written residency agreement, which we typically see for group homes, for all individuals supported that provides eviction notice, and this could be 30, 60 days. Is signed by the individual and or guardian and provides the same responsibilities and protections from eviction that tenants have under the landlord-tenant law of the state, county, city, or other designated entity. Provide to consult their legal counsel regarding landlord-tenant laws for their area. And so the Missouri Attorney General's website has information regarding Missouri's landlord-tenant law, and we provide you a link to that brochure on the next to last slide of the presentation. The next requirement for provider-owned and controlled is that each individual has privacy in their sleeping or living unit. So there's 3 components to this requirement. First, units have entrance doors lockable by the individual with only appropriate staff having keys to the doors. 2, individuals sharing units have a choice of roommates in that setting. And last, individuals have the freedom to furnish and decorate their sleeping or living units within the lease or other agreement. So here is that individuals have privacy in their homes, and the means of the individual to have privacy are not accommodated, then the process would need to be followed. Next requirement, individuals have the freedom to support to control their own schedules and activities, access to food at any time. Now, the requirement isn't saying that providers have to keep an open buffet 24/7, but it does if an individual works or may have an activity that runs late, how, as a provider, are you accommodating their meal times? Next, individuals are able to have visitors of their choosing at any time. Again, visitors of choosing at any time is repeated for provider-owned and controlled settings. So how the provider and the setting encourage and provide space for individuals to have visitors. The last is the setting is physically accessible to the individual. The provider ensure that the setting is accessible to the individual's mobility device as well as their needs, and that bathrooms, break rooms, all areas are physically accessible. And the last for provider-owned and controlled is any modification of the additional conditions under the CFR that's listed there must be supported by a specific assessed need and justified in the person-centered service plan. So this is the same requirement that we talked about above, and again speaks to rights restrictions or modifications to any provider-owned and controlled HCBS requirement. So again, anytime there's a modification to a provider-owned and controlled HCBS requirement or HCBS requirements, provider must ensure that there is specific CF language and processes that are incorporated into their practice and their staff training, as we discussed earlier in the presentation. And again, any modification or restriction of a right must meet those requirements, be reviewed by the due process committee, and be documented in the individual's ISP. And I won't go through those again because they're all listed in the guidance for you. Okay, the last 3 we're going to discuss are heightened scrutiny, and these 3 are specific to heightened scrutiny settings. Now, scrutiny is not the same as provider-owned and controlled. We've been asked that a lot. Scrutiny applies to all waiver services and settings and is defined as things which have the appearance of isolating or segregating individuals from their community or the appearance of an institution. It does mean that heightened scrutiny settings are not allowable. It means that these settings must go through a heightened scrutiny review process with CMS. It includes developing an evidence package, information from waiver participants, the provider, the staff, the community, and state review and licensing processes. See a final approval for these types of settings. Now, CMS was also that states do not create new heightened scrutiny settings, and there is a link with further guidance on heightened scrutiny, which is provided at the end of the presentation. Heightened scrutiny requirement is the setting is located in or adjacent to a publicly or privately owned facility that provides inpatient treatment. This would be a publicly or privately owned facility that provides inpatient treatment. For example, that would be a hospital or a nursing home. The next, the setting is on the grounds of or immediately adjacent to a public institution. And this would be, for example, a state habilitation center or a state school. Requirement, the setting has the effect of isolating individuals receiving Medicaid HCBS from the broader community of individuals not receiving Medicaid-funded HCBS. This category really is the most difficult to define. It applies to settings that appear to segregate individuals receiving waiver services from their broader community. This would be campus-like settings or congregate settings with on-site staff where all the services and activities come to that site. So that had the appearance of isolating those individuals. For is the beautician coming to the home to style the individual's hair? Does the medical doctor and therapist come to the home to provide services and therapies? Does the minister come on Sunday to provide church services? So again, the appearance of isolating those individuals. That would fall into this category include gated communities where only individuals with disabilities receiving waiver services reside, farm beds, and club apartments where only individuals with disabilities receiving HCBS waiver services reside. There was a lot that we covered today. So if you have any questions or need additional clarification, the division has created an HCBS mailbox, and emails are reviewed and answered by the HCBS team. Address is located on the last slide, and it is hcbs@dmh.mo.gov.
So I want to thank you for going through the guidance document, and I really want to encourage all providers, stakeholders, waiver participants to take a look at the document, especially providers. I think one of the things that we've talked about with other providers as we've worked through remediation is that there's an excellent resource to see in the first column what that HCBS rule is. In your second column of the document, really guides you on your conversations that you can have with each other as you're determining whether you meet HCBS compliance. It's a good discussion starter, kind of guides you through those conversations again. And the last column are things that will be looked at through your ongoing monitoring. And just like Leslie said in the beginning, you have to provide every component. These are just examples of things that you can provide. But definitely take advantage of this document that's out on our website.
And is the website link. So as we discussed earlier, there's the links to the CMS guidance on house rules and heightened scrutiny settings, the Office of Constituent Services link that takes you right to their page, and Missouri Attorney General's landlord-tenant law brochure.